Good morning, everyone. Welcome to our pop quiz webinar on split shared denials and how to pass. My name is Ashley Decoto, and I'm a specialist with our provider outreach and education team. On the call with me today is my friend and colleague, Leanne Foster, who you just heard from. Leanne is going to be helping out with the chat. This webinar is part 2 of our 2-part Back to School series on split shared services. Yesterday, Leanne held the Part 1 study hall session, which provided more details on split shared services. If you were not able to attend her session yesterday, that recording will be available within the next week or so. First, I have just a few housekeeping items to go over. We will have a recording of this session available in the Training Center on our website. The Training Center is linked here on this slide, and Leanne will be adding a link to the chat. It will be available on our website for the next 60 to 90 days, barring any technical issues with the recording. And you can access this without having to access YouTube, as we do recognize that not everyone is able to access YouTube at work. The recording will also be available on our YouTube channel as long as the information remains relevant and current. So you'll have that out there to rewatch, or if maybe you have someone in your organization that was not able to attend today and wants to watch the recording. Also in our training center, you can find a copy of today's presentation. So if you haven't already grabbed that, it is still available for download if you would like to have the presentation to follow along or maybe to take notes, though it's not required of you. We are taking questions through the chat today, which again, Leanne will be monitoring. I will check in with Leanne at the end of the presentation, time permitting, for any questions in the chat. Now, if we don't have time for live questions or maybe have more questions than time allows for, not to worry. I will put together a follow-up email that will include answers to all questions that we were not able to get to, and I'll send that out to all attendees. I will be answering those questions that were pre-submitted with registration throughout our presentation today. We would appreciate you taking some time to provide feedback on our education. Towards the end of the presentation, you'll be provided with a couple different ways to take our survey, and we would love to see your feedback specifically on how Leanne and I have structured this series into 2 sessions. Here we have our disclaimer slide. The information given today is as up-to-date and accurate as we can make it. Now, as many of you might know, Medicare rules do change often. We will respond to questions today, though, based on the information provided, but CMS rules will determine final coverage. The most current information can always be found on the CMS website, which we have linked for you here. And then lastly for this slide, CMS prohibits recording of this presentation for profit-making purposes. So if you are recording or taking screenshots, we do ask that you stop. We are recording this presentation ourselves, and we'll have the recording available on our Encore page in the Training Center of our website within the next week or so. And again, that recording will also be available on our YouTube channel. Because we will be using some CPT codes today, I do have a few quick disclaimers to share before we get started. On this screen, we have the CPT copyright notice, which indicates that Medicare does not own the CPT codes or their descriptions. Those are owned by the American Medical Association, or AMA. This is a copyright notice for the American Hospital Association, and this disclaimer states that the American Hospital Association is not responsible for, nor were they involved in the preparation of this material or the information provided today. Here we've included the acronyms that we'll be using today, and I have gathered these all in one place so you have this for reference. Some of you might be familiar with these, but I did include this as we may have some attending who are newer to billing Medicare and might not be as familiar with these acronyms. Again, just a reminder, if you've not already downloaded today's presentation, it is still available in the Training Center of our website under live events. So feel free to download that, and then you'll have a copy of this acronym slide as a reference. All right, for our agenda today, we're going to start out by doing a brief recap from Leanne's Part 1 Study Hall webinar yesterday, where she gave a more comprehensive overview of the split shared guidelines. billing requirements and documentation requirements. And again, if you were not able to attend that session, we encourage you to review the recording from the Encore page on our website or on our YouTube channel once that becomes available. Next, we will do a review of the top denials and rejections for split shared services. Then we have a Q&A activity planned. Lastly, again, if time allows for it, we will take questions through the chat. Also, I will be sharing some resources in today's presentation, and these may be resources you saw yesterday if you attended Leanne's study hall session, but we really want to make sure you have these for today's activity. All right, so let's start with a quick recap of Leanne's session from yesterday. Split shared services are E&M services in a facility where the physician and non-physician practitioner work together to provide care. Both the physician and non-physician practitioner must be enrolled with Medicare and able to submit E&M services under their own NPI. Medicare allows split shared services in a facility setting where incident to services are prohibited. The practitioner who provides the substantive portion of the service can bill the service to Medicare. So the billing practitioner would be whoever provided either the most time for the service or whoever documented a component of medical decision making, meaning the problem, data, or the risk. We had a pre-submitted question which asked for examples of how the physician or APP should be signing their split shared visits. And the answer to this is that the billing provider, the one who performs the substantive portion, must sign and date the documentation. So if you bill under the non-physician practitioner, they would need to sign the documentation. If you bill under the physician, they would need to sign the documentation. Regardless of who bills, the FS modifier must be appended for your split shared services. We had a pre-submitted question regarding modifier FS, which asked if you put modifier FS on your prolonged care code. And the answer to that is your prolonged care codes do not require a modifier. So the FS modifier would need to be appended to your E&M code, but it's not needed on your prolonged care code when you're billing for prolonged time. We had a pre-submitted question that asked for documentation requirements to support modifier 25. Now, this is not specifically related to today's topic, so I'm not going to go into a lot of detail on modifier 25, but modifier 25 is used when you have a significant and separately identifiable E&M service by the same physician on the same day of a procedure or another service. We do have a video on our YouTube channel that's specific to the modifier 25 requirements. Before we move into denials, we received a pre-submitted question, which was, can discharge services be billed as split shared services? And Leanne received this question yesterday, and she did receive some clarification that yes, discharge services are able to be billed as split shared. We had one additional question yesterday on this topic that came in after we closed out for questions, and that was, can you use time or MDM to determine the billing provider for discharge services, or must it be time since it's a time-based code? And there's nothing that says that it must be time or MDM for the substantive portion of split shared discharge services. You can use either time or MDM to determine your billing provider for a split shared discharge service. All right, here we have our top denials for split shared services. This is based on data for claims submitted with the FS modifier from April 1st through June 30th of this year. Our top denial for split shared services was claims denied while the beneficiary is in a period of managed care. And this would happen when they're enrolled in a Medicare Advantage plan. So you want to make sure to check eligibility, which is something you can do through our secure portal if you're signed up to use that. And if the beneficiary has a Medicare Advantage plan, the claim must be billed to that plan. Original or fee-for-service Medicare does not process those claims. Next was duplicate charges, which would happen if payment was already made to you for that split shared service for that beneficiary on that date of service. Now, if you believe your claim denied duplicate and error, you can submit an appeal. Next on our list is payment included in another service received the same day. So if your split shared services are denying this way, you'll want to look at the NCCI procedure to procedure or PTP edits. And this is how you'll find out if your service is included in another service provided that same day, and to determine if a modifier is allowed. And I've asked Leanne to place a link to the CMS NCCI page where you can find that information. To give an example of this denial, for split shared services provided the same day as another service or procedure, you'll want to look to your documentation to see if the service is significant and separately identifiable from that other service. If it does meet modifier 25 requirements, make sure that you check that a modifier is allowed for your service in that specific situation. Next, we have claim must be sent to the employee group health plan first. So if the beneficiary has an employee group health plan primary to Medicare, you'll submit to that plan before billing Medicare. And then our last top denial was units of service exceeded. And this is another case where it's important to verify the billing limits using the CMS NCCI edits page, specifically by checking the medically unlikely edits, or MUEs. The MUEs indicate the maximum number of units a provider would typically bill for a single patient on a single date of service. For example, you might be billing for, let's say, split shared critical care services with code 99291, along with the add-on code 99292 for each additional 30 minutes. According to the current MUE table, 99292 is limited to 8 units per day. So if you receive this type of denial for your split shared service, you'll want to refer to that MUE file to confirm the maximum allowed amounts. We did actually have a pre-submitted question regarding MUEs, which was, should we split bill services that are billed over the MUE so one claim line has the allowed MUE and the other claim line has the overages? And you would bill the total units on one line. Any amounts that exceed the MUE value would deny. All right, now for our top rejections for split shared services. Our first rejection here is claim lacks information needed for adjudication. So something is missing from the claim. And you'll look at the other reason codes on your remittance advice, and these would provide a bit more information. So this could be any of the items required for that claim to process, such as maybe the patient's date of birth or your place of service, for example. So you'll want to double check your claim form and make sure that all required elements are included and then resubmit your claim. Next on our list is claims for those beneficiaries who have railroad Medicare. And those claims must be submitted to the MAC, which is the Medicare Administrative Contractor, who processes railroad claims. And that will be Palmetto for your Part B railroad claims. You can verify that the patient has railroad Medicare by checking their Medicare card, and that would show Railroad Retirement Board and a red strip across the bottom of the card. Next is incomplete or invalid information for other insurance. If your claim is rejecting this way, you may want to check item 11 on your 1500 claim form or the electronic equivalent. The Claims Processing Manual, Chapter 26, this tells us that this is a required field, so you must include other insurance primary to Medicare in this field. If there is no insurance primary to Medicare, enter the word none. Leaving this blank will cause your claim to reject this way. Our fourth rejection for split shared services is invalid or missing modifier. Now we ran this data based on claims submitted with the FS modifier. So we want to make sure to only submit the FS modifier where appropriate. So if your place of service is 11 for office, for example, then the FS modifier would not be appropriate and your claim might reject this way. Split shared services are only available in facility locations and not in the office setting where Incident to services are allowed. Last, for rendering physician number invalid or missing, for these it might say denied on your reason code, but this is actually a rejected claim. Also on your remittance advice, the reason code actually says to submit a new claim, which is exactly what you would do here. Double check that you've included the physician's NPI and that it's the correct NPI, and then resubmit your claim. I've included this slide here as a reference to help kind of summarize what we just talked about for split shared denials and rejections. For your rejections, you'll fix the error and then resubmit the claim. Keep in mind that for rejections, that claim was not able to fully process, meaning a claim determination was not yet made, and the claim does not have appeal rights. Those must be corrected and resubmitted, or submitted to the correct contractor, for example, for those railroad claims. For denials, your next step is really going to depend on the type of denial you receive. Your remittance advice will really be your best source to determine what's next. It may indicate you need to resubmit your claim, in which case you would correct the error and resubmit. Now, in some cases, you may be able to correct a minor error through a clerical error reopening using our Secure Net Access portal. For example, if you need to add, change, or delete certain modifiers, let's say, for example, you accidentally added the FS modifier to an Incident to service, or maybe you forgot to append the FS modifier to your split shared service. These are the type of corrections that you might make through a clerical error reopening. And you may have denials that will require you to appeal if you disagree with the claim determination. And your remittance advice would include remark code MA01, which indicates that you have appeal rights. We did have a pre-submitted question indicating you would like to learn about filing appeals, so I did include a link on this slide with more information on how to appeal a claim. All right, next up, we have our Q&A activity. We have planned this activity to test your knowledge. For each slide, we will be launching a poll, and we invite everyone to participate if you can, and don't be afraid to take a guess if you don't know the answer. For each question, we'll give you all a few moments to submit your answer, then I'll talk about the correct answer. Also, there are a few websites you may want to reference for this activity, and I've asked Leanne to place links for those in the chat, so you'll have those handy in case you need them. So let's get started with our first question, which is, split shared services are provided in facility settings where Incident to services are prohibited. True or false? I'll give everyone just a moment on that. All right. It looks like we have actually 100% correct on this one. The answer to this one is true. This is the definition of split shared services as outlined by the Code of Federal Regulations, or CFR, which is the first of the links that Leanne added to the chat for this activity. So if you click on that link, for this section of the CFR, which is 415.140, this page will pull up. Split shared services are those provided in facility settings, or as the Code of Federal Regulation calls it, institutional settings. Split shared is only allowed in facility settings where Incident to services are prohibited. The last answer I included here because split shared and Incident to services are often confused. Split shared services are done by a physician and non-physician practitioner working as a group in a facility setting. Incident to services are provided in non-facility settings by someone other than the billing practitioner. So the key differences to keep in mind between split shared and Incident to are first the setting. Split shared is in a facility and Incident to is not. And the other difference is who is providing the service. Split shared is provided by both the physician and the non-physician practitioner. Incident to services are provided by someone other than the billing physician, but under their supervision. Another thing I want to point out on this page is here where it defines facility setting, you see this link here. And this link will take you to the Code of Federal Regulations section on incident to services. If you're looking for more information on that, I do encourage you to take a look at that page. And Leanne and I also did, and I didn't mean to flip back to that, Leanne and I also did a series last week on incident to services, and the recordings from that series are available on our YouTube channel if you're looking for more detail on incident to. So we'll move on to our next question. Our next question is, split shared services are not covered when the level of service is chosen by MDM. True or false? All right, looks like we have quite a few answers in. Give it just another moment. All right, the answer here is false. It does not matter if your level of service is chosen by time or by medical decision making. Split shared services are billed by the practitioner who provided the substantive portion of either the medical decision making or more than half of the total time. So you'll look at the total time documented and determine who provided the most time, or look at your documentation to see who documented, an element of medical decision making in full. Now, by documenting the element of MDM in full, what do we mean? Well, let's say, for example, that Nurse Patty and Dr. Smith are providing a service together. Dr. Smith documented that he reviewed the results of one test, which is part of the data element for medical decision making. But Nurse Patty documented that she reviewed the results of 4 tests, which tells us that Dr. Smith did not document that element in full in this scenario. So if using MDM to determine the billing provider in this example, it would be Nurse Patty. All right, next, for critical care split shared visits, the billing practitioner is determined by who provided the substantive portion of the MDM. True or false? Give it just another moment. All right, the answer here is false. The substantive portion for split shared critical care visits may only be determined by using time. Let's go out and take a look at where you can find that. So using the resources that Leanne put in the chat when we started this activity, we're going to go out to the second one, which is the Claims Processing Manual, Chapter 12. Now this may look familiar if you attended yesterday, but this manual will be a great reference for you throughout our activity today if you'd like to follow along. So once we open Chapter 12, what I want to show you is in section 30.6.18. Here we go, which you can find in the table of contents here. For whatever reason, this section isn't hyperlinked for me, so I'm just going to click on the section above it, which will get me still to the right area of this manual. So here you can see that section we're looking for on split shared visits. And there's information here on the definition of split shared, and they also define what the substantive portion is. What will help us with this question, though, is a chart on the next page. If I scroll down just a little bit, there we go. And this chart tells us how the substantive portion is determined specifically for each type of E&M service, meaning is it by time or medical decision making. So we see that the first three, which are other outpatient services, hospital, and SNF, these can all be determined by time or by MDM. But based on this chart, the substantive portion for critical care may only be determined using time. So for critical care split shared services, your billing practitioner would be the one who provided the most time. Another thing to point out here is under this chart, which reminds us that split shared services are not billable in the office setting or in nursing facilities. And we will be coming back to this manual later on, so feel free to keep that handy if you are following along. All right, next up, which of the following are eligible places of service for split shared services? Select all that apply. So our options are 11 for office, 21 for inpatient hospital, 23 for emergency room, and 31 for SNF. All right, looks like most answers have come in for that. So the answer for this one is all but the first option. Yesterday, Leanne provided information on eligible settings for split shared services, which included inpatient and outpatient hospitals, emergency departments, inpatient observation, critical care, and SNFs. For SNFs, keep in mind that split shared would only apply when they're in a Part A stay. If they're not in a Part A stay and the place of service is 32 for a nursing facility, then Incident 2 would be allowed and split shared services would not apply. The office or place of service 11 would also not be a valid place of service for split shared services. And this ties back to our definition per the Code of Federal Regulations. Since Incident 2 is allowed in an office setting, this means that place of service is not eligible for split shared services. All right, our next question. Which of these providers are eligible to bill for split shared services? Select all that apply. Is it an MD or DO? Non-physician practitioner? Providers not enrolled with Medicare? Or providers in an office setting? All right, looks like most everyone has their answers in. And the answer here is the first two. Both your physicians, meaning your MDs and DOs, and your non-physician practitioners are eligible to bill for split shared services. Regardless of whether the service is billed by your physician or your NPP, both providers must be enrolled with Medicare and able to submit E&M services. So if your MD and nurse practitioner are providing a split shared service, and the documentation shows that the MD provided the most time, your nurse practitioner still must be enrolled. You're not able to use documentation from a non-enrolled practitioner to meet split shared guidelines. The last answer here I talked about for our last question. Services provided in an office setting are not split shared services because this is a setting where payment is available for Incident 2 services. We had a pre-submitted question about billing providers, which was, can licensed clinical addiction counselors, or LCACs, be enrolled in Medicare, or are they only Incident 2? Licensed clinical addiction counselors can enroll as mental health counselors, but they would be billing behavioral health codes, not evaluation and management. Behavioral health Incident to services are different than what we're discussing today, but we do have a video on our YouTube channel specifically on that topic. All right, next. The NPP does not need to be enrolled with Medicare to provide a portion of the split shared service. True or false? All right. Most answers it looks like are in, and the answer here is false. Again, if your non-physician practitioner, excuse me, must be enrolled with Medicare and able to submit E&M services when providing a portion of a split shared service, even if the service is billed by the MD. All right, next up. An attestation statement by the MD stating they provided the substantive portion of MDM is sufficient to bill the split shared service under that MD. True or false? All right, the answer to this is false. Attestation statements do not take the place of required documentation, so you must have documentation of what each provider did and determine the substantive portion using that documentation. We had a couple pre-submitted questions regarding documentation, which were, what are the key components that must be in a split or shared services documentation? And we were also asked, what documentation tips do you have regarding split shared visits? So I'm kind of going to answer those together. Documentation must show the parties involved and what they did. It also must support the billing provider either provided the most time or the substantive portion of MDM. If using time, avoid ranges or general statements like, I provided the most time. If using MDM to determine the billing provider, be sure that the billing provider documented an element of MDM and that they provided that element in full. So the documentation would show if they did the assessment and analysis of the problem, they did the data review, or the risk assessment. If at least one element was documented in full by the MD or DO, this would support the MD or DO as the billing provider. But statements like, I performed a portion of the MDM would not be sufficient. Documentation should show what was performed. Our next question is, a statement by the MD stating they provided the most time is enough to support billing the split shared service under that MD. True or false? I'll give you just a minute or so. All right. So the answer again here is false. This is like our previous question. You would determine your billing provider using the documentation. The documentation will show that both providers are working together to provide the service. Each provider will document the service they provided, and you will use that documentation to determine who provided the substantive portion. A statement by the physician saying they provided the most time would not meet this requirement. And we had a pre-submitted question similar to this, which was, can the physician just state, I spent the majority of time, or do they need to state the exact time? And the same thing would apply here. Documentation must include the amount of time spent, not a generalized statement like, I spent the majority of time. That brings us to our next question, which is, when using time to determine who bills the split shared service, both face-to-face and non-face-to-face time may be counted. True or false? All right, lots of answers coming in. Just another couple seconds here. Yeah, most of you got that one. The answer here is true. And this is another thing that we can find in the claims processing manual. So I'm going to open that back up. And I'm going to scroll down just a little bit from where we left off to page 75. And this section gives us information, on qualifying time. This tells us that time may be counted whether or not it involves direct patient contact. Then we have this bulleted list of activities that may be included in time, such as non-face-to-face activities like preparing to see the patient, reviewing tests, ordering medications, and so on. This also provides a list of activities that cannot be counted in the total time, such as services that are separately reported. And that brings us to our next question. And our next question is, for non-critical care services, which of the following activities can be counted towards time when determining the billing practitioner? And you'll select all that apply. So is it preparing to see the patient, ordering medications, documenting clinical information in the medical record, or travel? I think everybody's using the reference. These answers are coming in really quick. Yeah, and everyone's getting this one right. Okay, so the first three are correct here. And this goes back to that list that we just looked at, and I think everyone's using, which is great. That's the claims processing manual that listed the activities that can be counted towards time. It also told us activities that may not be counted include travel, services that are separately reported, and teaching that is general and not specific to management of that patient. Another thing I want to point out here is the reason we specified non-critical care services in this question. Since critical care services can include additional activities that are bundled into the critical care visit, there is a unique list of qualifying activities. And CMS refers providers to use the CPT guidance on qualifying activities for split shared critical care visits. So you'll want to check the CPT book on what is considered qualifying time for critical care services. CPT gives examples such as time spent at the patient's bedside, or time spent on the unit or at the nursing station on the floor reviewing test results. It also specifies that time spent in activities occurring outside of the unit or off the floor may not be reported as critical care time, since the provider is not immediately available for that critically ill or critically injured patient. So just something to keep in mind for your split shared critical care services. All right, our next question is, which of the following are true of group practice for a split shared service? And you'll select all that apply. And our answer options are CMS does not define, the MD or DO and NPP may decide if they are a group, must be part of the same tax ID, and documentation demonstrates agreement. All right, it looks like most everyone has their answer in. So the answer here is all but the third option. And we have this information in the third link that Leanne added to the chat for this activity, which is our WPS page on correct billing of split shared services. And I've got that opened up now. So we have included a lot of information on this page that we've already discussed today, such as approved locations and information on determining the substantive portion. For this question, we do have a section, if we scroll down a little bit here, or maybe more than a little bit, here we go, on group practice. For the purposes of split shared services, there is not the requirement that both providers are under the same tax ID. This is not like for E&M services, where CMS has defined a group by same tax ID and same specialty. For split shared, CMS has not applied that definition of a group. Leanne gave an example yesterday where you have a group of cardiologists who are involving hospital-employed NPPs in the care of their patients. You would need to have an agreement or some type of contract which identifies how payment will be made between the parties involved. All right, let's head back to our activity. The next question is, who is responsible for reimbursing the provider that is not billing? Is it the patient, Medicare, the billing provider, or Leanne? All right, Leanne, you're off the hook. Nobody selected the last option. So the last answer to this is the billing provider. We talked about how CMS has not defined a group, and a physician and non-physician practitioner may decide to be part of a group. The billing provider would be responsible for reimbursing the other provider who does not bill Medicare for that service. All right, a couple more questions. For this one, we have a scenario where nurse practitioner Sloan spent the first 10 minutes with Betty beneficiary, who's in the hospital. Then Nurse Sloan and Dr. Bueller meet for 5 minutes to discuss Betty's treatment. Dr. Bueller then spends 20 minutes with Betty. Who would bill for the split shared service? Is it Dr. Bueller, Nurse Sloan, neither, or would Dr. Bueller bill it as an incident to service? All right, looks like most of the answers have come in. So the answer here is that Dr. Bueller would bill this as a split shared. One thing we wanted to point out with this type of scenario is that time spent together. So the 5 minutes in this situation where Nurse Sloan and Dr. Bueller are meeting to discuss Betty's treatment, that 5 minutes only counts once. So you could add it to Dr. Bueller's time, which would mean Dr. Bueller provided 25 minutes and Nurse Sloan provided 10. You would not add 5 minutes to both the physician and non-physician practitioner's time. All right. Our last question is, which of the following statements are correct for split shared services? Select all that apply. Is it both practitioners must provide face-to-face services? Both practitioners must document their service? Does it only apply for established patients? Or one practitioner must provide a face-to-face service? All right, it looks like just about everyone has their answers in, mostly correct. The second and fourth answers are correct here. Both practitioners must document their service. At least one practitioner must provide a face-to-face service, which does not necessarily need to be the billing practitioner. There is not a requirement that both practitioners provide face-to-face services. Split shared services are not only for established patients. Split shared services can apply for both new and established patients and for initial and subsequent services. A pre-submitted question we had asked, can the physician doing the MDM be performed virtually via audio-visual technology? So first, check the telehealth list for your service to determine if that service can be provided via telehealth. For awareness, telehealth still has flexibilities that were initiated during the COVID-19 public health emergency, or PHE. At this time, CMS has stated in the E&M Services Guide, which was updated last week, that telehealth flexibilities will expire on October 1st, barring any congressional action. For split shared services, one of the practitioners does need to be face-to-face with the patient, not via telehealth. And we did just hold a webinar on telehealth on the changes related to these flexibilities. And the recording is available on our website and on our YouTube channel. So that does wrap up our Q&A activity, but it looks like I had a little bit of an audio issue on slide 17, so I'm going to go back to that for just a minute. Give me just a minute. Slide 17. There we go. Just want to make sure I have the right slide here. So on this one, the answer for this one was all but the first option, which is 11. To the following are eligible. So eligible places of service for split shared service from this slide would be 21 for inpatient hospital, 23 for emergency room, and 31 for SNF. And we also talked about how 11 would not be an eligible place of service for split shared because the office is a place where incident 2 services are allowed. And the same would apply for place of service 32 for a nursing facility. That would not be an eligible place for split shared services. All right, hopefully that sums up what we talked about there. Now I'm going to share a few resources. Let me just get back to that slide. All right, so here we have our resources, and these should all be familiar. First, we have our WPS page on correct billing of split shared services. Next is the Claims Processing Manual, Chapter 12, which we looked at a few times today. If you downloaded this presentation, the hyperlink on this resource is not the right one. It will take you to our WPS Split Shared page. Still a good resource, but it's not the right link. I have asked Leanne to place a link in the chat again to the Claims Processing Manual, Chapter 12, to make sure that you have the correct link for this one. Last year on our resources, this was one of the first things we looked at. That's the Code of Federal Regulations. And this section of the Code of Federal Regulations, again, is what defines split shared visits, and it also defines the substantive portion. So we do have a little bit of time left, and Leanne and I will take some questions from the chat. Leanne, are there any questions in the chat?
We do have one that hasn't been addressed. The question is, does the billing provider have to document on 2 of the 3 components of MDM to support the substantive portion?
No, what we're looking for when you're using MTM to determine your substantive portion is that at least one element is documented. So that would be the problem, the data, or the risk. But what you want to keep in mind, though, is make sure that that element's documented in full. So like in the example I gave, we saw that the doctor had reviewed one test, but we know that the nurse reviewed 4 tests. So that was that element in full, the 4 tests. The doctor in that particular case did not document it in full. All right, Leanne, anything else?
That is the last question we have in chat, Ashley.
All right, great. Well, we will wrap up. Few things I want to share before we close out. In a few minutes, you will receive an email to thank you for attending, and you don't want to delete this one without reading it. The email contains your certificate of achievement, and it will look like what you see here on your screen and has your name and contact hours if you need to turn it in for credit towards continuing education units. If you do not receive the email, a few things may have happened. First, you may want to check your spam or junk folder. Be sure to add messenger@webex.com to your safe sender list so that any future messages will show up in your inbox. Also, if you joined by phone only, you would not have received this email as there's not a way for us to capture your email systematically from our attendance record. No need to worry though. If you joined by phone, you are able to email us with the phone number you joined with, and Leanne will be adding that email address to the chat in just a few moments. And we also have it listed on the next slide. If you do think of any additional questions, you have 7 days from today to submit those. You'll send those to our education mailbox and make sure to include pop quiz split shared denials in the subject line so they make sure those emails come to me. Please keep in mind that I'm not able to access any claims history, so you will want to contact customer service for any claims related questions. All right. Lastly, please take a few minutes to complete the survey. Tell us what you liked, what we can do better, and suggest topics for future education. There are a few different options to take the survey. You can use the link in the chat, or when you exit today, you'll be prompted to go to an external site, and that external site is the CMS Qualtrics page. The prompt will look like we have shown here in the picture with a little yellow triangle. And we included this image so that you know this is safe. It's not malware or anything like that. For those listening through our website or through YouTube, you will also have the same opportunity to provide feedback. You will have a survey card at the end of the presentation. You can scroll to the end to see the link, or the link is also available in the description. I did want to include this to show that we do make changes based on your survey feedback. Here we've included some changes that were made recently. Based on your survey comments, we added chapters to our YouTube videos so you can easily find specific information in the video that you might be looking for. We've also added training indicators to our education to help you better understand if that education is suitable for you. We've also started our all-day virtual education events based on survey feedback. And these are the Medicare Education Expos that will focus on specific topics. Our next one is coming up October 16th. That's going to focus on the Medicare claims process. All right, and with that said, I want to thank everyone for their participation in today's activity. On behalf of myself, Leanne, and all of our provider outreach and education team, thank you so much for attending. We look forward to your survey comments and hope to have you join us again for future events. You may now disconnect.